Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for tuning in to my latest video. So the patient who attended with bilaterals, when we say bilateral we mean both ears, extremely blocked, fully occluding earwax, and the right ear in particular, which is the ear that we're performing the procedure in at the moment, the entrance of the ear canal is very narrow and the ear canal itself is very narrow. So it was a bit difficult and tricky in this ear. To add to that, the consistency of this wax is quite sticky. There's a lot of dead keratin there. So when we're suctioning the wax out, it was pulling in large ribbons and it was almost stretching the wax as opposed to removing large lumps. And when you've got sticky wax like this, it can block the suction tube quite a lot. Now, typically when you've got sticky earwax, I feel there's a high composition of dead skin within the wax. So 60% of earwax is actually dead skin, dead keratin. And when you've got a high composition, like when you've got sticky wax like this, I feel the composition is slightly higher, so about 70 to 80%. And this skin, as it dies, it becomes damp and wet, and which gives the wax its kind of mushy consistency. So I've put some olive oil earwax drops in just to change the consistency and bind this wax together. So to get access to the ear, we have to really widen and stretch this ear open. And the way we do that with an endoscope, and this is for all the clear wax delegates that I've trained, just to remind them, we pull the ear back and up, and what that does, it not only widens the ear canal, but it straightens it. So there's two bends in the ear. The ear canal is like an S-bend, and by pulling it back and elevating the ear canal, so we do that using the external ear, the pinner, it widens and straightens the ear. I then insert the endoscope into the ear canal and I'm pushing the cartilage, the posterior cartilage, so the back part of the ear canal, to the left to keep this ear canal ajar, keep it open, which then enables me to insert the suction probe into the ear safely without making contact with the canal wall. So this plug, it's extending all the way to the eardrum, and because the entrance is narrow and the ear canal widens up somewhat, it gets stuck at the entrance because the end part of this plug of wax is larger than the patient's ear canal entrance, so it's a natural obstruction there. So we can have to wriggle this through, and you can see me there really wriggling it. You can just see how narrow this ear canal is, and I'm really stretching this ear open. And then get the suction probe in. And because it's a lot of keratin as well, it sticks to the ear canal wall, so it's a bit of a tug of war going in within the ear canal. And again, it's just trapped at the entrance, and the ear canal entrance then collapses it upon itself to almost like an alligator or crocodile jaws. It's slamming down on the wax. So again, I have to straighten the ear, and I'm really wriggling this through. You can see how much force I'm wriggling this in. We're at the entrance now, in the cartilaginous portion. It's not going to be uncomfortable for the patient, and I'm really going for this. I mean, I could possibly at this point use an ear hook, but the wax is coming out, so I just continued at this stage with the suction. Now this lump of wax now, it's a bit firmer, so I've got a better suction grip, which enables me to remove it. If it was a bit gooey and sticky, so I probably would use a Jobson horn, although it would have been quite difficult getting a Jobson horn or ear hook into the ear because it was so narrow. Huge piece of wax removed. So there's the patient's eardrum. Just to the left, we can see the patient's, probably the head of the incus. Head of the stapes. So there's three bones in the ear. You've got the malleus, aka the hammer bone, the incus, aka the anvil bone, and the stapes, aka the stirrup. And in that ear, it just looked as though the eardrum was retracted, sucked in, and it was wrapped itself either around the long process of the incus or the head of the stapes. Just in the left ear, and similarly to the right ear, the patient's ear canal has really collapsed the entrance. Again, quite sticky wax when we're near the entrance, and I'm just trying to leverage this off. I think here I'm just using an ear hook. Sometimes when you've got stodgy wax like this, the ear hook it acts like a hot knife through butter. It just dissects the wax. It doesn't actually extract it. We got a piece there, a lot of skin. You can see there's some dead skin there, that residue. I'm similarly to the right ear, so to stretch the left ear open, I'm pulling the ear back and up, inserting the endoscope, pushing the endoscope now to the right-hand side of the ear canal to keep the ear canal ajar, which then enables me to insert the instrument. It's a bit of a technique, but once you've mastered it, and articular wax earwax will be testament of that. There's no ear, it doesn't matter how small and narrow it is, you can get access into any ear. So just like the right side, I've just instilled some olive oil spray just to change the consistency of this wax. Again, I just lift it off the canal wall. You can see I'm really just lifting it up. So now it's detached itself from the canal wall. I'm going to wriggle it out of the ear. So it's quite a significant blockage there we had with the patient. Ear canal's clear. And I'm just going to mop it up at the entrance with a fine end gauge. Just some dead skin here. I'm just going to try and tear this without it clarinetting. Clarinetting is when sometimes when you suction skin, the skin violently flaps at the tip of the suction probe and it emits a very loud squeal. Take care, guys.